Morning all. Neil here. It's 10 o'clock down in San Diego. Good morning. Again, those on the East Coast, good afternoon. And really appreciate you folks joining us. Frankly, it's quite an honor for you to take the time. In addition to the CE, we hope that you find the information helpful and informative. We're talking about frankly, a revolution in veterinary medicine. By all means, at any point, give us feedback. Mike, our CEO here, who will participate in the presentation. We have Bass, who's head of marketing, is manning the questions. By all means, ask questions and Bass will respond to them as they come in. Okay, let's get started. Once again, welcome to all, especially those who have just joined. We have pretty much, if not all, most of the states represented in Canada, as well as a number of folks in other countries. SignalPET already installed in a number of practices. We have already accumulated thousands and thousands of active cases, in addition to the hundreds and hundreds of thousands of cases that we used to develop the system. And what I have compiled today are the 10 most common abnormal findings for us at SignalPET. I'd like to give special thanks to our medical director, Chelsea, Dr. Chelsea Kunst. Chelsea is by training a radiologist. She's also a wonderful person. And Chelsea has meticulously and methodically helped to create our protocols that really are the foundation of the system. As an orientation, I'll first talk about signal ray and what it means. Then Mike Delinka, our COO, will give a brief overview of the system, really so you have a frame of reference as we continue the continuing education talk on what a test is, what a signal means. Then I will go through the 10 most common findings. Again, this is amongst thousands and thousands. And I will identify the definition of each test, as well as, where appropriate, the clinical implications. First, I'm going to talk about SignalPET. It is novel, it's new for veterinary medicine, and I'd like to give a little bit of background. We're talking to you here in San Diego, and San Diego here on the West Coast is no doubt the West Coast is very technology oriented, and particularly in San Diego, biotech or medical technology, really it's a leader. As an area, it's a leader in that field. We assembled, in addition to veterinarians, we assembled truly a world-class team of engineers to work together to see if we could utilize machine learning or artificial intelligence to accurately predict radiographic findings. And before it was a business, it was a project. Could this be done? It is no doubt being done in human medicine. We explored the human models that have been done and decided to do this for veterinary medicine by veterinarians. So the first thing we did was the obvious. We accumulated a very large database of films, including interpretations, radiologist interpretations for those films. And we simply, and I know alienate the engineers, guys, don't be angry with me, but we fed those into the computer. They can talk for months on actually what they did, but I'll just say they fed that into the computer. Combination of films combined with radiographic interpretations to see if we could determine a correlation to accurately make a prediction. So when the computer saw those films the next time or similar films, they could predict what the abnormalities that were there. And we failed. We could not make a correlation between the radiologist interpretations and the database of films that we had. So then we went back and tried it again. And this time, rather than using old interpretation, we proactively recruited input. So we took a set of films. We asked a number of specialist peers to review those films with knowledge of why it was being done. Please help categorize the answers in specific categories. Use your professional judgment, but help categorize the answers in specific categories. And unfortunately, the system again failed. We could not have get the AI to lock onto an algorithm that correlated the specialist input with the films, with the reading of the films. So then we took a third approach and we revisited the data. And rather than leaving the interpretations open, we developed a structured approach to the interpretation. We defined what normal was. We defined what abnormal was. We utilized millions, literally millions of data points. This was a tedious, it was a painstakingly slow process. It was frankly a very expensive process. And the AI locked. When we ran the algorithms, the AI locked. It worked. That was the eureka moment. That was truly a eureka moment. The take-home message was, when there was variability in interpretation, the AI could not lock. And I call the AI the truth seeker. It is consistent. So if there is variability of results, there's a failure on consistency of prediction. However, when there is structured data, when there is consistency in interpretation, but there's variability of image quality or variability of image, maybe the patient is turned, maybe it's breathing, maybe it's not an exactly perfect image, that can actually be overcome with significant data. So the quality of the film wasn't as significant as the quality of the interpretation. And when we focused on providing consistent, objective, concise interpretations, the system was able to learn, and the system learned well. And it was successful. Once we had the technology, we went ahead and created a test panel. And very similar to a chemistry panel or blood work that you submit, say, for example, you submit a Chem 22 or however many tests are available these days, and you have 22 tests. What we now say is when we submit radiographs, we reveal specific tests. And we have close to 50 tests available today. And those tests are abnormalities noted on the radiographs. And either it's positive or negative. We either have an abnormality or we don't have the abnormality. Very similar to a chemistry panel test result. And we have another comfortably 20 tests that haven't been released yet. We're waiting for these tests to, if you will, settle, have everybody get used to and accustomed to using the system, and then we'll progressively reveal more and more specific tests. We also have a dental panel that is coming soon. We actually were going to release it in the near future, in the next few weeks, but given that most hospitals in the country these days are on emergency-only basis, no electives, we decided to hold off on the dental panel, and we will release that once we return more to normal as a country. So what I'm going to do now is turn the microphone over to Mike Delinka. Mike is our Chief Operating Officer, and he actually does, many of you have actually spoken with Mike, does a fantastic job of showing the system. And again, when you look at the system, it is to learn a basis of the test results, and then I'll discuss their meaning when Mike is done. Mike?
Thank you very much, Neil, and appreciate everybody joining on here. It's really impressive to see how many folks were able to join us, so thank you for taking the time today. I'm going to take you through a really brief overview here of how the system works and how you can utilize it and see it. And so what you're looking at here actually, and as Dr. Shaw mentioned before, the goal here is to really look at this in the same format that you look at blood work, running a Chem 22 for specific test results for actually the most common radiographic findings that you would see in a general practice or emergency setting. With that being said here, this is really a simple system to use. This is actually our PAC system, as you can see here, web storage. It's just a Google Chrome tab, and all of your information will come set, as you see here, in the format of names, patient name, patient ID, and findings. Where things start to change here, as Dr. Shaw mentioned, was under those finding sections. These are, before you even dive into your study, the way that the machine learning works is it doesn't differentiate between early, mid, or late stage of a disease. It differentiates between the confidence level that that normality or abnormality exists. So as we can see here, red is standing for abnormal. That might be vertebral heart score, mid-abdominal mass, peritoneal fluid, pulmonary mass, and yellow is standing for possible hepatomegaly. And this information is all coming to you right away. And so we can click right here into our study, and the information will pop outside. Needs and capabilities such as side-by-side comparison, back to home by clicking these buttons here. What I want to bring your attention to is on the far right-hand side here, where you can see all of the test results as I scroll down in the format of greens and reds. Again, this is based off confidence level. So 4 bars green is normal, and 2 bars green is likely normal. 4 bars red is abnormal, and 2 bars red is possible abnormal. This system has become known actually through all of the hospitals are using this around the country and around the world as their second set of eyes. Actually, they come into here and actually can just kind of quickly see and confirm with their own findings that they see based on the totality of the signalment they have at hand. So if I scroll through here on this example case, all of the lung patterns are looking normal. If I hover over any of these information here, it will populate exactly what we are looking for to find, or as a description for that issue. And then if you can see here that you'll have the little circle that's here where it says PMS, and you can see that that's here. If I click on this here, we see a red line populate here, and 2 red lines populate here on the left-hand side. What these red lines here are telling you is they're telling the doctor the data or information that was found, that abnormal information, was found both in images 1 and 2. It's possible, right, that we maybe would only find a mass in image 1. We see that a region of interest is populated here, telling us where those abnormalities were found. This exact looking on this, it's pulling only from the left lateral, as we can see here, which would make sense for a measurement. It's doing a region of interest finding here. It does an exact tracing of the heart, measuring from the base of the carina to the apex, the widest spot, the 4th vertebrae, and measures backwards, and it's giving you an automated vertebral heart score found down here. The system is automatically reviewing the entirety of the study for all of the different test results at the same time. So it's finding normals on all of the issues we look for: bone lesions, fractures, shoulder issues, pelvic issues, spinal issues. It looks a lot in the abdomen, as Dr. Shaw showed you before. We focused a lot in the abdomen and thoracic panels, as that was really a highlighted area that doctors are wanting to gain more information. And as you can see here, everything came back normal. And then here's a possible hepatomegaly for enlarged liver. So this information comes back to the doctor in clinic in 10 minutes or less, 365, 24/7, as well as it comes in an email format of a quick report. And this gives you kind of a little quick insight into what we do as a system here and the information that is being provided back in real time. Part of this was to be able to provide you that second set of eyes while the patient is still in the room, and to be able to do so in a really quick turnaround time at a high value add. So that was just kind of a brief overview to show you how that works. I'm going to hand it back over here to who will kind of go through what those most common radiographic findings mean for us.
Thanks, Mike. So, when we determine, again, amongst thousands and thousands of the 10 most common signal ray abnormal findings, I've listed them here in order of frequency. And I'll go ahead. It's a little difficult to look at. What I'd like to take from this information is changes, general bronchointerstitial changes to the lungs are common. Spondylosis is common, followed by, less commonly, joint effusion of the stifle, changes to the hips, gastric distension, pleural effusion, and I'll go through each one specifically. If I were to reorder these findings, again, the two most common are changes to the vertebral column, spondylosis, and changes to the general changes to the lungs, a bronchointerstitial pattern, and then followed by 8 more, much more specific findings. I'm now going to go through each medical abnormal finding. In other words, each signal, or as we call it, each test result. Again, I'll go through a description of what to do. Keep in mind that you no longer have to determine this for yourself. It's important to know the background. It's important to know how we came to the conclusions or the predictions that we have come to. However, you no longer have to do it by yourself. In other words, you need to know how to do long division manually. It's important to know the basis, but once you have a calculator, you don't have to do that anymore. And it's the same analogy. So spondylosis. Of course, it's abnormal bone growth that connects the ventral aspect of 2 vertebral bodies. Let's look at some examples. This is clearly an older patient with significant spondylosis, effectively fusing the vertebral bodies together, specifically the lateral thoracic and the lumbar vertebral bodies. This is a case that is it's probably a young patient. And if you look at spondylosis, film may have been taken for other reasons. However, we can find spondylosis right here in a much earlier stage. What is this? T13, 12, T12. A common place, not on this patient, but another common place in the early stages, we often see it, is sacral region. And this is a middle stage. You don't quite have bridging yet, but you have early bone formation. It's an earlier phase of spondylosis between several of the lumbar vertebrae. Again, routinely we'll pick spondylosis even when we're not. Now, I know that generally speaking, the spondylosis is an incidental finding, and folks tend to not pay it a lot of attention. It's the body. However, let's keep in mind why it is happening. It's the body's attempt at stabilization of an unstable area. So spondylosis or bone growth forms in an attempt to stabilize an unstable area. Maybe there was a herniated disc. Maybe there was a herniated disc. Maybe there was an injury. Maybe there was another reason. But the body is reacting by laying down bone. It's a progressive disease. No doubt, there's a variability of clinical signs. It can be mild. It can have a little bit of arthritis, or it can progress to actual neurologic signs. And no doubt, medical and supportive care is appropriate. The question that I have, and I simply don't know the answer to, is now that we're picking up spondylosis early or noting it early, should we not maybe consider conservative medical management when it is noted? In other words, if it happens to a dog that is a young adult, would holding back from jumping, using ramps, avoiding getting picked up in the car and out of the car, would that be beneficial rather than ignoring it and waiting till it's severe? It's a question that I don't know the answer to. Some of you folks may know the answer to, or we can develop it over time, a protocol. The next most common finding is what I would call a general bronchointerstitial pulmonary infiltrate, a general bronchointerstitial infiltrate in the lungs. Now, this is important to know the meaning of a bronchointerstitial infiltrate. It's effectively a catch-all for normal versus abnormal lungs. When a clinician looks at lungs, whether it be a radiologist or a practicing clinician or a specialist of another sort, and says, gosh, the lungs look busy. This is a bronchointerstitial pattern. It's a generalized increase in opacity. The challenge is, and I'll show you on the next slide, you can't always assume that that is abnormal. And typically, I don't necessarily look for the lungs to see whether or not they're busy. I look at the vasculature, because if there is an infiltrate in the lungs, it will affect the appearance of the associated vasculature. And especially at the periphery of the lungs, look for the tapering vessels, the tapering pulmonary vessels. Are they distinct? Are they crisp? Do they taper well? If you can see that, the lungs are probably normal. If you can't see the vessels well, if the vessels appear hazy or foggy, then you probably have a pulmonary infiltrate of some sort. To make it more challenging, lungs are tough, guys. So to make it more challenging, when we look at lungs, of course, you can have a legitimate infiltrate. And that infiltrate can be any sort of pathology, or it can be benign age-related change, if you will, old dog lungs. In addition, 3 common causes for a falsely abnormal appearance to the lungs can be obesity. If the patient is really obese, then that can appear as an increase in pulmonary density. If the lungs are underinflated, either it's a largish patient and they're recumbent, and you have underinflation, or simply said, it was the world is real, it's not ideal, and it's hard to get in some patients, especially if they're panting, a shot on peak inspiration. It may be an expiratory shot, expiratory film. That can alter the appearance of the lungs. And of course, if there's underexposure, the film is too light, then that can change the appearance of the lungs. So let's look at a couple of films. So this is a patient. I would imagine that it looks like it's got a large heart as well. His VHS is likely to be enlarged. However, if you look at the dorsal portions of the lungs, where we normally look for the pulmonary vasculature, you can't really see the pulmonary vasculature. So I would say, yes, this would be a positive for bronchointerstitial infiltrate. You cannot find those pulmonary vessels. This is made even worse by the fact that this patient is obese. Look at all the fat above, and look at all the fat here. So this patient is obese. It's an expiratory film. So it's a tough one to read. However, you would not be able to say that those lungs are normal, even though they got some potential artifact of an obese patient and on an expiratory film under inflated lungs, but you cannot see those vessels, so you would have to call that positive. This is a great film of pulmonary vasculature. If we look at the cranial lobes, you can actually trace these pulmonary vessels out, and they do a pretty good job, not an excellent job, but a pretty good job of tracing those out as they taper down. But if we look up here in the dorsal regions of the lungs, you really can't find those vessels. It appears foggy, it appears smoky. So yes, positive for bronchointerstitial infiltrate. Well, the here you can actually tapering nicely. Again, you don't. It really are smoky. They're not distinct. This dog actually has some mineralizations in its lungs, but this would also be a positive for bronchointerstitial infiltrate. So the question is, what does it really tell us? It doesn't tell us a specific disease process. So when you have a positive bronchointerstitial infiltrate, it doesn't tell us a specific disease process. We've actually gone through and delineated different features to tell us specific disease processes, but it's a quick and dirty, is this normal or abnormal? in which case, if it is normal, you can be confident that the lungs are normal. If it is abnormal, then it could be anything from artifact to actual disease. As far as actual disease, we've created additional, this is where the beauty of artificial intelligence and machine learning, it continuously gets better. So from this general category, we've created more specific categories to significantly improve our interpretations, and I'll cover some of those a little bit later in the talk. A next common finding, and this actually was a little bit of a surprise. I didn't realize it was as common as it is. However, pleural effusion. And pleural effusion, no doubt, is fluid accumulation in the pleural space in between the thoracic wall and the lungs. And this fluid can, in a severe case, can actually drown the lungs, so to speak. The lungs are floating in a sea of fluid. And in milder cases, you can see wispy fluid accumulation between the lung lobes. So, sorry guys. So this is a severe case in which we have, in this kitty cat, we have quite a bit of, it looks like the mouse is giving us a challenge. Sorry for that hiccup. I've lost my mouse. But in the severe case, we see the lungs literally floating in a sea of fluid, and there is so much fluid there. It's actually obstructing the major structures in the chest, specifically obstructing visualization of the cardiac silhouette, obstructing visualization of the major vessels. So this is a severe pleural effusion.
Stay here.
Please.
Oops, the system just froze. All right, we're back. We're back. This is another severe case where the oops. Okay. Guys, can you give us just 1 minute for technical difficulty with the slides? There you go. So this is another severe case, again, where there's a tremendous amount of fluid and the lungs are almost floating in the fluid. A VD, or probably in all likelihood, this was a dorsal ventral view, again, with significant fluid in the cranial and the caudal aspects. And this is a case that I'd like to, it's a little bit more interesting, where no doubt on the cranial right side of the thorax is some significant fluid accumulation. However, importantly, and I've lost, the mouse is coming in and out, but importantly, on the left side, you can see a wispy amount of interlobular fluid. And that's a line, I'm trying to get the mouse to work, but the mouse isn't operating. But it's on the left side is a wispy amount of fluid, and that would be a positive for pleural effusion. The biggest differential the most common differential for pleural effusion is hydrothorax or a transudate. In kitty cats, heart failure is the most common. So without a doubt, heart failure is the most common in kitty cats. With dogs, not quite so often heart failure, even right-sided heart failure can occur, not as commonly. However, dogs with a low oncotic pressure, with a low serum protein level, can result in effusion out of the vessels or transudate out of the vessels. Less common causes are inflammation there, pleuritis, pyothorax, chylothorax, certainly leakage of lymph fluid can occur in some cases. We see that occasionally. Hemothorax in trauma or coagulopathies or neoplasia can periodically occur. Without a doubt, a serum chemistry panel looking at oncotic pressure, especially in dogs, is helpful. Thoracocentesis, no doubt, is diagnostic and therapeutic in these cases, and especially in kitty cats, a echocardiogram would be appropriate. So now we're going to be a little bit more specific. We discussed a pulmonary bronchointerstitial infiltrate. Again, the good news is it's good to have the background, but the test results are done for you. You don't have to determine this anymore on your own. So keep that in mind. So now we're going more specific back to the lungs of what we've now called a cranioventral parenchymal infiltration of the lung tissue. And this is when we have either an interstitial or an alveolar pattern in the cranioventral lungs, specifically the right cranial, the right middle, and or both segments of the left cranial lobe. It doesn't have to be just specifically in the cranioventral portions. It can be elsewhere in the lungs. However, if it is in the cranioventral portions, it brings up some specific differentials. Here is an example, and again, guys, sorry, we're playing with a point, hopefully in a few minutes, but clearly in the cranioventral portion is a significant and in the cranioventral region. Here is a VD, and on both sides, you have significant in the cranial portions of the lungs, you have significant infiltration. In fact, you can see air bronchograms. And here in this kitty cat is no doubt there is a diffuse pattern, but specifically in the cranioventral region, there is significant infiltration of the lungs, again, with air bronchograms. So when we look at cranioventral pulmonary infiltrate, think pneumonia. Most commonly, and pneumonia can be any infiltrate. It could be cells, it could be neoplasia, it could be pus, it could be just fluid. Most commonly in dogs, though, think aspiration pneumonia. You can have a viral pneumonia, no doubt. But in dogs, most commonly, especially if there are air bronchograms suggestive of an alveolar pattern, think aspiration. In cats, again, cats, heart failure, there's no pathognomonic signs of heart failure in cats. Very possible to have a cranioventral pattern and a diffuse pattern with congestive heart failure, as well as a pleural effusion. Cats are tough. Most common findings is pneumonia. Infiltration of the lungs with heart failure would also be considered a form of pneumonia. The next common finding, again, a little bit more common than I would have expected, would be pulmonary masses. Occur more frequently than I would have thought. No doubt, round soft tissue opacities, larger than little nodules, typically on a view box. I'm going to say this as a kind of a gross estimate, knowing that magnification varies, but is on a view box, larger than 2 centimeters. Originating within the parenchyma, round soft tissue with typically well-marginated densities. There's a pulmonary mass in the caudal thorax, caudal to the heart, well differentiated. Sorry, I just want to add as well, if you notice, these films, these are actual cases, live cases, they're not all perfect. They're not all perfect. They're not the perfect exposure. They're not the perfect positioning, and that's okay. You can get a heck of a lot of information from films that are not picture perfect. And that's what we strive to develop with the systems, and the systems showed that you can, that films don't necessarily need perfect. I think actually, just as an aside, the bigger challenge we have is when we have lots and lots and lots and lots of films taken on a study, that folks sometimes tend to overtake the number of films, And typically you can get by with certainly maximum of a body section. 3 films per body section is typically all that you need. Here's another example of pneumothorax, excuse me, of pulmonary masses. And what we have are several distinct masses in this patient. And these masses, little technical detail, but here we go. Difficulty. These masses are well encapsulated, but they also appear to be cavitated. And that actually can occur. It's interesting that either these masses either penetrated through the lung tissue and resulted in the thorax, or did a full aspiration, a transthoracic aspiration to do cytology on the lung tissue, and there was a creation of a little bit of a pneumothorax in this patient. Another example of well encapsulated. No doubt, primary differential for masses is neoplasia. Most commonly carcinomas. Can be primary, can be metastatic. Note, you can have other neoplasias, metastatic sarcomas and such, but a primary carcinoma or metastatic carcinomas are common. Other differentials that are significantly less common, especially with large-ish masses, include fungal diseases, fungal granulomas, lung lobe torsions, as a result of trauma, contusions, or even pulmonary abscesses. All right, we're really doing well on time here. We've got 5 more common abnormalities to go through, but right now, this is a reminder, if you wouldn't mind completing the survey. There are 3 questions that have been asked as part of the survey. If you wouldn't mind please entering your answers to those questions, that would be fantastic. It's with regards to the status of radiology in practice today. And importantly, in addition to this webinar, I will be hosting a webinar for radiologists only for a fair number of the radiologists later today. And in part, we're going to use the data from these questions to present to the radiologist this afternoon. Please be candid, be comfortable, answer on what's real for you at your practice. I'll go ahead and give you a minute to take a break, answer the questions, perhaps grab a cup of coffee or water, and then we'll resume. Number 6 on our list of 10 is a caudodorsal pulmonary parenchymal infiltration. So again, we already discussed cranioventral, which was consistent with pneumonia or infiltrate of the lungs, of which heart failure in cats is a possibility. Aspiration is common in dogs. Now we're looking at a caudodorsal parenchymal infiltration, which is the presence of an interstitial or alveolar pattern in the caudodorsal lungs, which are the right caudal, the accessory, and or the left caudal lung lobes. So here's a classic example of, see a cardiac. The mouse has left me again. Oh, there it is. Sorry guys, the mouse is giving trouble. What we see is a significant infiltration in this caudodorsal lung field, and it's actually obscuring this portion of the heart. And if we look closely, I would imagine that right here, atrium. So caudodorsal often goes hand in hand with specifically cardiomegaly or specifically left-sided heart failure, and so it would be consistent for there to be left atrial enlargement in the presence of a caudodorsal pattern. Again, you no longer have to delineate your own; it's done for you with the signals or with the test panel. Here's another case with a significant caudodorsal infiltration, and there's the mouse. And in fact, it's significant enough to see, you can actually see air bronchograms appear in the caudodorsal field. Interestingly, as is often the case with cardiac disease, and just as a by the way, you see a distension of right here of the caudal vena cava, because as the heart is not able to push blood out as easily as it did before, or as efficiently as it did before, you get, of course, blood backup, and it can back up in the caudal vena cava as well. And here is a VD, and again, you have cardiomegaly, but specifically caudodorsal infiltration of the lung fields. And if it looks general, again, let's go back to what we said before about vascularity. Can we see vessels here that are distinct and tapering nicely and crisp? We do not. We do not see pulmonary vasculature that is crisp and tapering. And that's a result of the pulmonary infiltrate in the caudodorsal fields. Most commonly, pulmonary edema. So without a doubt, most commonly pulmonary edema, typically cardiogenic, typically heart failure. Remember as well that pulmonary edema can occur often due to neurologic conditions. For example, if a patient is seizuring significantly, it can result in pulmonary edema. Or say it's a young dog that chewed an electric cord, that can result in neurogenic pulmonary edema. Other less common differentials are neoplasia and evidence of fibrosis and other changes to the lungs. Number 7, gastric distension. And this is when the stomach is significantly distended beyond its normal contour, and it can be distended with food, with fluid, with gas, or with foreign material. No doubt, it's very difficult to tell at times whether it's food or foreign material. This is a patient with significant air distension of the stomach. The difference of, we have different tests of gastric distension versus a distension with volvulus, a GDV. So I'm not mentioning GDVs here, they're not common, but when GDVs occur, the system picks them up. This is a simple gastric distension, an aerophagic dog. If you look at a little bit of lung fields there, you can see that the lung field, it's got disease, it's probably panting quite a bit, and therefore aerophagic. And here's significant food. So gastric distension with food or with a foreign body. It's hard to tell, but you got food distension or soft tissue density material in the stomach. Not the most significant clinical finding unless there's a history of vomiting. And that's how, in practice, I would always view gastric distension. Is there a history of vomiting? When there's gastric distension, especially with a soft tissue density, and there's a history of vomiting, we more commonly think of a foreign body. It's unable, the dog is unable, typically a dog, can be a cat, the patient is unable to bring up what's in its stomach. It's trying. So I think that's when you worry about who's missing a pair of underwear or such. Otherwise, if it's aerophagic, you look for a reason that the dog is, or the patient is aerophagic. All right, 3 more. We take a lot of knees, no doubt. As a profession, we take a lot of knees, typically in dogs. Doesn't always have to be a dog, but typically in dogs that are acutely lame. And a stifle effusion is a fluid buildup in the cranial portion of the stifle joint in the space just caudal to the patellar tendon. No doubt this is a dog that's had surgery, it's a flexed knee, and what we can see is, here's the interpatellar fat pad right here. Usually that fat pad comes in a nice triangle like this, and that fat pad is displaced by the soft density fluid that is accumulated within the stifle joint here. And here also, is a positive for stifle effusion. This fat pad, which is normally right here, has been displaced, in this case in the dorsal aspect, by fluid that is formed below, right here below the femur. And it's actually not that uncommon to see a wisp of fluid along the line of the femur. If it's following the contour of the femur and it's just a small wisp, kind of a hair width bit of fluid, that's actually okay. But when we're displacing the fat pad, when it's in an abnormal, uneven appearance, when it's so no doubt this amount, then that is abnormal. That'd be consistent with positive test for positive test for stifle effusion. And here is another case. Again, not a 100% ideal film, but we can comfortably see fluid that has formed here in the stifle. Most common, any injury to the joint, any loss of integrity to the joint can result in an effusion. Any ligamentous damage can, without a doubt, a rupture or a tear of the cranial cruciate ligament is the most common. In fact, signs of acute limping with a positive stifle effusion on radiographs is justification for surgical exploration and or stabilization of the knee. More unusual cases of stifle effusion can result in arthritis, immune-mediated or septic, significantly less common with a different history, but certainly they do occur. Hips are very interesting. When we initially approached hips, number 9, we looked at secondary changes and we more or less assumed dysplasia. However, no doubt you can have osteoarthritis, degeneration of the hips for reasons other than hip dysplasia. So over time, again, this is where the system gets better and better over time, we started separating out dysplasia from just plain osteoarthritis with a lack of dysplasia. So I'll talk about, which is more common, is hip dysplasia. And interestingly, we see it a lot, but they're not necessarily hip films, because whenever a VD film is taken of the abdomen, unless it's a really large patient, then we typically have a nice VD shot of the hips. And so we can make an assessment, specifically the system is able to make a call. And so what by exact definition, hip dysplasia is defined as inadequate coverage of the femoral head by the dorsal acetabular rim with secondary osteoarthritis or bone deposition that the body does in an attempt to stabilize the joint. We actually go with a more significant algorithm, and as the system analyzes the image, it really takes multiple points into account. But for the sake of this overview, we'll go through a brief algorithm, which is it a pelvic shot? Is it a VD pelvic shot? Is the femoral head coverage symmetric? Is the femoral head coverage greater than 50%? Are there widened joint spaces? Sometimes the joint space isn't widened, but there's divergence. There's an angle created between the acetabulum and the femoral head. Is the view oblique? It can be difficult to tell, and we're able to train the system to analyze for an oblique view, which obscures or we don't want to get false positives. So this is a really not the greatest, but not a bad shot of the pelvis. This is unusual, and because we have asymmetrical disease where we have a pretty good looking hip here, we have pretty good femoral head coverage, nice smooth femoral head, acetabulum over dorsal rim is over here, and here we have what is likely subluxation of the femoral head, very poor coverage, not a hell of a lot of secondary signs, but early secondary changes to the hip joint. Here we have profound disease on both sides. You wonder if the femoral head's ever were within the socket, were within the acetabulums in this poor patient. And we have secondary thickening of the neck. We have secondary flattening of the femoral head. But we have severe dysplasia with secondary changes on both sides. And here is a lighter view, however, more than adequate to analyze by the systems. And here we have bilateral hip dysplasia, whoops, with divergence of angle between it and the acetabulum, with changes, flattening of the femoral head, as well as other secondary changes, thickening of the neck and changes to the acetabulum, consistent with chronic dysplasia on both sides. Remember, even though it is now seen when you're not specifically looking for hips, the system will register and will analyze the hips for you. We may have dysplasia, and again, conservative management, being careful, swimming is very appropriate for dogs, but to treat the clinical signs, because dogs can have profoundly abnormal radiographs and be clinically relatively normal, or they can have relatively mild changes radiographically onto the hips and significantly affected or significantly lame. So remember to treat according to the clinical signs. All right, we're on our number 10. We're on our last most common abnormality. Here we go, bladder stones, needs no introduction. Kind of a fun one after getting through lungs and such. Here's a beautiful picture of a bladder stone, no doubt. That is an obvious. But what will soon be coming to add to the panel is if we look over here, we actually see some renoliths. So even though we don't have it available on the panel, it will, we've already done the work. Once folks get used to the system, we're just waiting for folks to get used to the systems. We'll start showing additional abnormalities in addition to this bladder stone and identify that this patient has renoliths as well. Another bladder stone, obvious, but even when they're not obvious, we'll pick. And again, here's some stones, probably not calcium in origin, but could be, resulting, this bladder looks pretty perennial and it's pretty distended. Again, the system continuously gets better. Right now, we're picking up bladder stones for our own purposes. We're not releasing the information until everybody gets comfortable with the system. Actually, the system gets better. And if you can look on this patient, you just lost the mouse, but just caudal to the os penis is a density consistent with a urolithiasis. And so this is urethral, sorry, consistent, this is a urethral stone. So this patient has a urethral stone, likely with secondary, some degree of obstruction and enlargement of the bladder. And so the mouse is back, here we go. And in the future, once everybody settles with the system, we'll automatically pick up urethral stones as well. Thank you. Thank you. That was a lot of information. There was a lot of information all at once. However, keep in mind, the good news is that you don't have to remember all the rules. The system now does it for you. That we automatically utilizing artificial intelligence and a peer-reviewed quality control process, we review the films for you. And I'm going to now turn it over to for questions, and actually turn it over to Mike. Mike, do you mind jumping in?
Yeah, sure. So thank you, Neil, and thank you everybody for joining here. So great to have so many people on here. I just wanted to reiterate, for those of you who are interested in learning more, testing out or using the SignalPET system that we mentioned, it is 10 minutes or less response time, 365, 24/7. It takes less than 10 minutes to install with no hardware needed, software fees, contracts, or anything of the sort. And lastly, it's a very affordable rate in order to support you to review and have a second set of eyes on all radiographs of $10 per study. You can go ahead and book a time with our team by actually going to calendly.com that you see there /SignalPET/webinar to get your own hospital up and running. You can check out more information or request a demo on our website at signalpet.com. And that ends our meeting. Thank you.